So how do you then, because we keep circling back to molecular testing, because that is, I think, the way things are going. There was even a big discussion in one of the oral sessions at ASH about doing away with blast percentage altogether for distinguishing MDS from leukemia. We should really be just relying on other factors like molecular testing. How do you incorporate molecular testing into your risk stratification?
Well, certainly if there's something, I see what would be a low-risk MDS patient who has a P53, I put that patient in a totally different category, that they have P53-related disease and they have a very poor prognosis. So again, people don't always play by the rules. Certainly if I see 6 or 7 abnormalities that are molecular, even though if it's a low-risk patient, I begin to really worry that that patient is in a higher risk category. If I see a simple DMN-T3A or I see a TET2 as the only abnormality, that gives me some reassurance that, that patient is probably not going to progress as quickly. So I really do use that information in a lot of ways. I also see, I'm lucky enough that some patients were able to see progression of their molecular. So they may have come with a TET2, but when I do the next bone marrow, 6 months later, they suddenly have acquired 2 more abnormalities. So that's really important too, because it's a dynamic way of determining that this patient may not do well. So I find that, it can be very helpful in an SF3B1. If that's what they have, then I feel very reassured that that patient is going to have, a more indolent course. So I think it's very, very helpful in allowing us to have another tool with which to stratify patients. Sort of how this works out in the long run, I think it will be interesting as we gather more data, as looking at those patients who are getting whole genome sequencing and seeing if we're stratifying, if we stratify even more dramatically, are we going to be able to determine those patients who need to go to transplant right away or need a special therapy because of their genetic abnormality?
I think the importance also is that we are at the edge, or we are almost there, where we are using some of this information to tailor treatment accordingly. So patients that have P53 mutation, we are sending them to clinical trials that look promising in those patients. Patients with SF3B1 may have certain options soon. Patients that have an IDH1 or IDH2 mutation may benefit from some treatment. So we are starting to incorporate those in our decisions for management. One thing, like we talked about, I think we are focusing mostly on disease-related factors, but in the prognosis on the outcome and risk stratification are always host-related factors. So we have to think of the comorbidities for the patient, the frailty. You could look at patient numbers, they look perfect. You walk into the room and the patient cannot get from the chair to the table to be examined. And obviously we have always to keep those factors. And there are several models that try to incorporate comorbidity, frailty. There are studies that actually just look at the fatigue degree. And it's almost as predictive as IPSS high or low in predicting the outcome for patients. So always we have to keep the host-related factors, particularly if we're thinking of a transplant for the patients as well.
So interesting, because even in the IPSS revise, I think they thought age and performance status both mattered relative to survival, but not for leukemia evolution, which is why they weren't included, but they mattered, obviously. So I think, performance status definitely plays a lot. But back to the NGS, the molecular sequencing, I think, yes, it helps all of us for identifying targets, for prognostication, for transplant purposes, but it's still at its infancy. I mean, it's really hard to say and perhaps I find it to be more helpful therapeutically in the relapse setting, because a lot of times patients may acquire certain mutations they may not have had in the beginning that may be helpful therapeutically. So more to come on that, I'm sure.
My general approach to mutations, and this isn't perfect because we're not at a perfect place with this either, if you're doing kind of a quick and dirty, I will upstage patients one category for poor risk molecular abnormalities. And that was actually shown by Raphael Behar in a paper. So patients who had specific abnormalities, and actually Rami, you mentioned them earlier, things like P53, EZH2, ASXL1. If a patient you would have categorized as having low risk disease, you move them up to intermediate 1. Patient who was intermediate 1, you move up to intermediate 2. And this is important for when to refer a patient to transplant. for MDS. We tend to transplant patients who have higher risk disease up front, and patients who have a lower risk disease, we wait until their disease evolves. So that does influence me nowadays to actually refer somebody to transplantation.